How is new home? How is new home?
The management is really responsive. They fixed everything. Like
That's
actually,
supposed to do.
yeah, but my previous management was
That's
really
home. Home, right? Home.
Yeah, that's
Kind of like they
casual.
they ran from home, right? Their home.
It's home like an email. I wasn't home. They fixed the window and let me know. Like we came and it's nice.
So we don't have to pay this year. This fall. Pay. No, not pay. The April.
I think we have it.
We didn't have any. The Sam said he sent out like I don't know, something
But
like
yeah, but you're right. Tomorrow there was able lab.
yesterday was also.
Yeah, yesterday. Sorry, I always miss this.
Right.
Yes, yesterday I saw Dr.
So I was wondering
so happy.
why they didn't just give us pay.
Even last fall we didn't have any.
That was extremely impossible.
This year we also have a tight schedule.
Tight schedule, but something I don't know something. Pay 3. No.
Happy birthday. Thank you. Did you guys match it the t-shirt today?
Muslim.
Good morning.
How are you? Good. I saw Christine on the phone weekend. Something.
Yeah, sure.
And we miss you. And she's from this. Oops. Oh.
No, she will bring it. But then just as a backup, we'll bring the cup.
Muslim, you look so tidy. You clean. What happened? What happened? Semester look. New semester look.
What do you
New semester look.
Did you get any able lab duty this semester?
lab duty?
Able lab.
Able.
Did you get?
No, I don't think they will give us anymore, right?
What?
I mean, yesterday was the first able lab. And
Yeah, so the first civil lab, I believe they are mostly introductory and they don't need TI. I don't think so.
but we should get the
they-
schedule by now.
Yeah, they'll share.
So now
What is it today? Like it is Tuesday, Wednesday. They'll have one more able introductory.
it's just so early.
I was hoping that we will not
They'll
be.
definitely get. They'll definitely get.
No, that's what I was thinking, but then
It's too late this time. We
For
got
me,
a
this
little.
semester it is relaxed, like no DA duty.
oh yes.
Good for you.
You and
Group
Asif,
search.
both of you have
And
like separately.
Rahima.
Asif has something
different
for
Rahima.
calculation pharmacy.
Calculation. Yeah.
What? Why
Rahima.
Rahima is not getting it yet?
She's doing 我号没问题 very responsible 号没问题 I couldn't clean up this time. I have
I'll be getting pretty close to the end of this particular handout. Then we'll go to the next one. Let's see. Right there. What we need to do is here.
You have to go here. Why? In.
Recording in progress.
Good morning. So what we're going to do now is do a sheet screen share. think we're going to be talking about allosteric antagonism. And let's see if we can stop this share for a moment, and we'll go to the whiteboard. So we go there. Here we go. Text. Here we have percent response. All right. So, if we're looking at a allosteric antagonist, right? So the opening question is, what kind of binding does an allosteric antagonist do? How does one define an allosteric antagonist? What do you think? What do you think?
So, the ligand, if the ligand is an antagonist and it binds to a site away from the actual receptor.
From the primary binding site.
Correct. And but in doing so, like if it affects the activation or inactivation of the
Mhm.
primary receptor.
Right. So it's a non-competitive antagonist, right? And last Thursday we talked about non-competitive antagonists, some of which were related to, let's say, an irreversible binding to the primary site, maybe covalently or something like that. So it's a non-competitive. And an allosteric binding site is also non-competitive since it doesn't bind to the primary site where the agonist might bind. And so from the standpoint of dose response curves, what's the shape of the curve? Sigmoidal, right? And so that is without any kind of antagonism. And then if you have, let's see, text. Fit very well. You might get something that looks like this. Where I want that, I want this. So why that doesn't change colors beyond a, well, anyway, the key thing is there's a decrease in Emax, right? And also there's a shift to the right, and also the slope of the curve is diminished. Okay? And then as you increase the concentration of antagonists, just like for irreversible binding, you get further decrease in EMAT and maximum response and Emax, as well as a decrease in EC50, or at least a shift to the right, decreased potency. So this sort of mimics the same kind of thing. Now let's go back. Go to screen share. Here. Allosteric potentiation. All right. Well, rather than redrawing the whole thing, I'm just saying a dose response. What would you anticipate? How would that look? Allosteric potentiation. If you have a sigmoidal response and then you add something that binds to an allosteric site, from a mechanistic standpoint, how would a ligand binding to the allosteric site that potentiates an agonist, from a mechanistic standpoint, how would that work? What do you think?
Switch.
Well, just a second. How would that work?
I think the graph will go down at one point.
For potentiation?
We are talking about inhibition, allosteric antagonism.
Actually, now we're looking at potentiation of an agonist. So this
Oh,
is not
okay.
an antagonist.
Okay, no, I was
So
thinking
how would it look? And what, before we see how it looks graphically, from a mechanistic standpoint, what would that mean?
I think the EC50 value would get lowered
Right,
and the graph would shift towards the left side.
right. And so that's correct. And so my follow-up question for anyone in the class is, why? How does an allosteric agonist that potentiates, or another drug that potentiates the agonist? Yes.
Maybe binding to the non-primary site
Yeah.
helps the agonist to bind as a superfit
Okay.
towards the primary site.
So put that in terms of affinity.
Increases the affinity.
So
of
it
the,
can increase the affinity,
yeah.
and also it can if you're looking at second messengers, it can enhance the affinity of binding of the second messenger. Or if it is like an ion channel, and here the prototype would be a benzodiazepine, it can prolong the duration of opening of the ion channel. And so both of those would tend to enhance the effect of the primary agonist binding to the site. Does that make sense? Yes.
So, Dr. Johnson, when you say it also directly impacts the secondary messenger, do you also mean that it is bypassing the primary receptor and
Well, if you consider, let's say, receptors that have a ligand binding site, right, that alters the conformation of the receptor, activating the receptor, if the receptor is in an active conformation and there is a second messenger, there is a binding site for the second messenger, and you could perhaps increase the affinity of the binding site for the second messenger by altering the conformation of the receptor. Does that make sense? Okay. So essentially what you would have here is just the shifting to the left of the dose response curve. And what about Emax? Would that change? Probably not, right? Because once again, the maximal response is a function of the biochemistry of the cell. I mean, even if you increase the binding, you can only increase, let's say, heart rate so much, or blood pressure so much, or whatever the function is. So this is essentially what we've already been talking about: agonist, antagonist, competitive antagonist. Shift the dose response curve to the right, but does not affect Emax. Non-competitive antagonists shift the agonist dose response curve to the right and decrease Emax, but they also decrease the slope of the curve. Okay. Partial agonists, Chantix, we already spoke about that, binds competitively with a full agonist, so competitive binding will decrease the pharmacological response to the full agonist, and it can do that by essentially stabilizing the receptor in either a non-optimal conformation, or it can just shift the resonance of the conformation of the receptor in such a way that it doesn't spend as much time in the act of conformation. So in considering, how would you pronounce Verenic? Say again? Chantix. So it decreases the person's craving for nicotine by decreasing activation of the nicotine receptors. By the way, does anyone know the area of the brain that has overall responsibility for reinforcing behaviors? Does anyone know that in neuroscience? Well, you all have access to the internet here. Why don't you ask Google and see what it says? So the area of the brain that functions for behavioral reinforcement or for addiction.
Mesolimbic dopamine pathway.
I'm sorry, say again?
Mesolimbic dopamine pathway.
That's right. It is a mesolimbic dopamine pathway, but that identifies the pathway. It doesn't identify the nucleus.
Frontal cortex and basal ganglia.
I'm sorry, say again?
Frontal cortex and basal ganglia.
Right, that's a broad area. What does it say about the nucleus accumbens?
Nucleus accumbens.
Right?
Motivation, experience of reward.
Right, right. And in terms of the mesolimbic tract, that is dopamine. So in terms of neurotransmitters, dopamine is the common denominator for just about any addiction, whether it's alcohol,
Yes.
gambling, drugs of various flavors. It all works through dopamine. And so if this drug, Chantix, is a partial agonist at the nicotinic receptor, what in the world does that have to do with dopamine and addiction? What do you think? I know we're putting in a little neuroscience here, but what the hell? Pardon me, it's fair game. This is sort of a mechanism.
It's basically disturbing the balance between acetylcholine and dopamine.
Right. Well, there is a balance if you consider movement in the basal ganglia. Are those in terms of cholinergic neurotransmission and dopaminergic neurotransmission? Are the receptors that bind acetylcholine in that system nicotinic receptors? Are they? Aren't they muscarinic receptors? Or are they nicotinic receptors? I thought they were muscarinic receptors.
Yeah.
Right. But the point I'm trying to make here is that even if the common denominator at the nucleus accumbens is dopamine, the release of dopamine is influenced in this case by activation of nicotinic receptors. So a lot of times in neuronal pathways, you have, it's just one neuronal pathway being influenced by other types of neurotransmitters, cholinergic neurotransmitters that in this case are binding to nicotinic receptors that then typically have an influence on a particular pathway. What kind of receptor are nicotinic receptors? Ion channels? Right, so ion channel for what? Well, it's not an ion channel for acetylcholine, it's an ion channel for an ion. Which one?
Gotcha.
It's mostly sodium, right? There can be some calcium, but it's mostly sodium. And so in this case, it works by decreasing the influence of the nicotinic receptor on the dopamine channel. Or, right, so that way dopamine is not firing as frequently, and there's a decrease in the reinforcing effect of dopamine on the nucleus accumbens. Let's consider basic pharmacological principle. Sometimes my spelling is really bad. Does additive really have two D's or one?
Two.
Okay, thank you. All right. So, if you have two drugs, let's say that are both agonists, and they work through the same mechanism. So, as an example, let's consider naproxen and ibuprofen, right? So those are both non-steroidal anti-inflammatory drugs. And does anyone know what the mechanism of action of NSAIDs is? They inhibit cyclooxygenase, right? Which is the enzyme responsible for the synthesis of what? Prostaglandins. So you have less prostaglandins. Prostaglandins are of various kinds, but they play a major role in being a mediator of inflammation. And inflammation tends to sensitize nociception, so you have pain. So just in terms of binding to the target, enzyme here is not a receptor, it's an enzyme, but the kinetics is similar. Oh, ibuprofen and naproxen, I actually have it written down there. They work the same way. And so it's just a matter of the overall concentration at the enzyme. So 1 + 1 = 2. If you have two drugs that produce the same effect through different mechanisms of action, and here we have Percocet, a combination of acetaminophen, which is a pain reliever, with oxycodone, which is a narcotic. The combination of the two gives you greater than additive effects, supra-additive effects. So in that case, 1 + 1 = 5. I personally find, I find acetaminophen on its own in terms of pain relief, sort of meh, not so much. If you actually combine it with a opiate, on the other hand, you get a great deal of synergism between the two. From a clinical standpoint, what is the advantage of doing a combination like acetaminophen, oxycodone, versus just upping the dose of oxycodone?
The combination lowers the risk of developing any dependency on oxycodone.
Right, so you essentially decrease the incidence of adverse effects of the opiate, so you don't get as much things such as constipation, respiratory depression, just foggy brain, sedation, all of that stuff. So there's a real clinical benefit to that. Just out of curiosity, quick show of hands, have any of you ever seen the movie with Jack Nicholson and Diane Keaton called Something's Gotta Give? Oh, well, I'll give you a synopsis of the movie, okay? To illustrate the point, okay? Very good movie. I'd recommend it. Actually, maybe I'll make it homework. You can get on Netflix. Jack Nicholson plays the role of an older Lothario kind of guy, maybe in his 60s, 70s, and he's quite the ladies' man. And he develops a relationship with a young woman, maybe early 20s. And he's anticipating an intimate encounter with this young woman. And so, like many older men, he has erectile dysfunction. So he takes some Viagra, right? And without getting into too much detail, the mechanism of Viagra is it increases the second messenger cyclic GMP, which then increases blood flow and corrects the erectile dysfunction. And so he's having his intimate encounter with his young girlfriend and has a heart attack. So gets transported to the hospital, goes into the emergency room. The doctor happens to be Keanu, how do you pronounce his first name? Keanu Reeves? Keanu Reeves is the doctor. And he's lying there, and the doctor's just about to start nitroglycerin, right, which is commonly used to treat chest pain associated with heart attack. And one of the questions Keanu Reeves asks Jack Nicholson is, now, you haven't taken any Viagra, have you? And Jack Nicholson, because the girl was just sort of standing right there, said, no. So Keanu Reeves, starts the IV with the nitroglycerin, and sort of steps out. The first thing that Nicholson does is he rips the IV out of his arm. Why is, well, the point, and why I'm bringing it up, is nitroglycerin and sildenafil, Viagra, both are vasodilators that work through different mechanisms of action, and there is a toxic interaction because of the massive vasodilation, which then would lead to shock. Right? So that 1 + 1 equals 5. So you don't have to watch the movie for homework. I'll just tell you the rest of the story. Jack Nicholson convalesces at the home. They were having their liaison at a beach house owned by her mother, the girl's mother. Jack Nicholson convalesces at the beach house, gets to know the mother, falls in love with the mother, and the rest of the movie is sort of the complication of the romance of this guy and the conflict between the mother and the daughter. It's a comedy. It's really funny. I'd recommend it if you had a chance. Okay. All right. Should I give you the ending of the movie? Okay. Jack Nicholson and Diane Keaton, who plays the role of the mother, have this conflict, but they wind up falling in love and have the happy ending to the movie. And the daughter is happy to move on to some other relationship, and that turns out okay for her. So it's a nice Christmas story kind of. All right. So you get positive synergism here, and what's going on with that? All right. Drugs don't always produce the same effects for each individual, and there can be variability in the response, and that can be based on how sick the person is, right? The age of the individual, just in terms of the way they respond. the genetics of the individual? What could be going on with the genetics of the individual that could produce an individual response? Any thoughts?
Ethnicity effects. The ethnicity, the race.
Ethnicity, sure. So why? How would ethnicity play a role in the response to drugs? Think about the molecular level. What do you think? Yes.
So I'm thinking two possibilities. So first, possibility is when people has like a single nucleotide polymorphism,
Right.
then they can develop like a different phenotype, so that they can make their metabolism or like some kind of enzyme make it like a little bit different. And the second possibility is if they have like like a cytochrome P uh, for 50,
Right.
like so if they I heard like some people have like two kinds, like a rapid metabolizer or like a slow
Right.
slow metabolizer, then it can affect the metabolism of actual the medicine.
Well, you're exactly right. So, just between ethnic groups, or even within an ethnic group, there can be genetic differences that can affect enzyme structure, which then affects enzyme function, which then can have an effect on the kinetics of the drug in terms of metabolism and elimination. Also, these kinds of genetic changes can also relate to differences in receptors. So some receptors can have more affinity or less affinity, or even there could be different numbers of receptors. So the concentration of receptors can also produce a response. So you can have individual genetics. Previous drug administration. So there we're talking about tolerance, right? And mechanisms for tolerance. And with repeated exposure to a drug, the receptors can either be desensitized or they can be internalized. In either case, if there are fewer receptors, that drops the Emax. We already spoke about ED50, right, last week. And here we're essentially talking about potency within a population. The dose will be effective in 50% of the population, so that's the median ED50 for a population. Mean lethal dose is the dose of a test population, not people obviously, but experimental animals that will kill 50% of the animals. Therapeutic index is a measure of the difference between, or the ratio of the lethal dose to the effective dose. If the ratio is small, that means that the lethal dose is close to the effective dose, which means that the drug is inherently hazardous. Can anyone name for me a drug that you're aware of that has a low therapeutic index, or the LD50 is close to the ED50? Digoxin, right? We spoke about that before, where digoxin is a sodium potassium ATPase inhibitor. Putting aside an allergic response, where would you put penicillin? Has that got a low ED50 or a low therapeutic index or a high therapeutic index, and why? It's got a high therapeutic index. Why would it have a high therapeutic index? What's the mechanism of action of penicillin?
It's a cell
Well,
wall.
I'm gonna go down to the end there. Do you remember?
I'm just trying to recall. Is it metalactamase inhibitor?
I'm sorry, say again.
Inhibits the
Well, it inhibits a particular enzyme that's responsible for what?
for it acts on the positive agent of the infection. So not on
Yeah, well, how? Anybody?
It's on the cell wall.
That's right. It inhibits cell wall synthesis of
Bacteria.
typically gram-positive bacteria. So why would that mean that it has a high therapeutic index?
Humans don't have
Human
cell
cell
wall.
does not have a cell wall.
That's right. Yeah, mammals don't have cell walls. So as a consequence, putting allergic reaction aside, you can give huge doses of penicillin and you're not going to get any real serious adverse reaction. Margin of safety, that is the ratio of LD1 to ED99, so you're essentially narrowing the window in order to get a really safer dose. Hopefully you're getting a drug that is effective 99% of the time, but only lethal 1% of the time. So they're sort of connected, but it's just another representation. Drug interactions. You can have pharmacokinetic interactions, concentration of drug at the site of action. So here we're talking about agonist-antagonist interactions. It would be a good example. You could also, though, have competition for transport enzymes from the GI tract. I'll give you an example there. The major drug that is used to treat Parkinson's disease is L-DOPA, right? That's because dopamine doesn't cross the blood-brain barrier, but the precursor does. Structurally, L-DOPA is a large neutral amino acid, right? And so if someone, they take the drug orally, they consume the L-DOPA, large neutral amino acid, absorption of amino acids from the GI tract, there are three transporters. One for acetic amino acid side chains, basic amino acid side chains, and neutral amino acid side chains. So you can inhibit absorption if, let's say, a person has Parkinson's disease, they take their L-DOPA, and then they have a steak or they have fish, and all the amino acids in the protein, the large neutral amino acids in the protein, will compete with the L-DOPA for absorption from the GI tract into the blood, and so that's not so good. So if someone has Parkinson's disease and they want to maximize the absorption of their L-DOPA, what kind of meal do you think they should have when they take the L-DOPA? Carbs, right? Because then there's much reduced, if any, competition for the L-DOPA transport. Metabolism, competition for metabolic enzymes. We have drug interactions. Give you another example, practical example. Many, many years ago, before I came to Duquesne, I used to work in a poison control center in the largest hospital in the state of Maine. And occasionally we would have someone who would present to the emergency department who had drank some windshield washer fluid intentionally. And the reason is frequently one of the major ingredients of windshield washer fluid is methanol. And so the antidote for methanol ingestion is ethanol. So plainly, these individuals had an alcohol addiction and were looking for a direct line because they would get the ethanol intravenously and have the effect. The thing is, does anyone know what the primary enzyme is for the metabolism of the ethanol?
Alcohol dehydrogenase.
Alcohol dehydrogenase, and it works just as well for ethanol as for methanol. Methanol, the parent compound, is relatively non-toxic. It's just eliminated in the urine, no pharmacological effect. The initial metabolite of methanol is, anyone know?
Formic acid.
It's formaldehyde.
Formic
And then secondarily after that, it goes from formaldehyde to formic acid.
Yeah.
Very toxic. Very toxic. What's the primary metabolite of ethanol? Acetaldehyde,
Acetaldehyde.
which then goes to acetic acid, right? And so the reason for infusing the ethanol is it inhibits the metabolism of the methanol. The methanol then gets excreted in the urine, and the patient is saved. Competition for metabolic enzymes can have interactions. That's just sort of one extreme example. But if you have different drugs that are metabolized by, let's say, the same P450 mixed function oxidase, you will slow metabolism, which then can raise blood levels of the drug, which then can have the blood concentration rise above the therapeutic range into the toxic range. Competition for renal transport enzymes. Okay, the kidneys work in a couple of ways. One, there is filtration of plasma, and you get filtrate, tubular fluid, right? Then with the tubular fluid, there can be reabsorption of essential nutrients, things like glucose and amino acids, etc., etc. There can also, though, be secretion of waste products, typically organics. And there can be competition for renal transport enzymes. And one example I'll mention is people that have hypertension. Common drug used to treat hypertension is something called a thiazide diuretic. Hydrochlorothiazide is probably one of the very most common drugs used to treat hypertension. And it is secreted into the tubules through a transport enzyme. Uric acid is transported into the tubular fluid by the same enzyme. As a consequence, people that are on hydrochlorothiazide, and once you're on that drug to treat hypertension, I mean, you're on it forever. They have to be careful sometimes about their diet, because if they are eating things that will result in increase in uric acid, they can develop hyperuricemia, which then results in a very nasty acute inflammatory disorder called, does anyone know?
Gout.
Gout. Very good, very good. And so that's an example then of a drug interaction related to composition. And all of those are pharmacokinetics. Pharmacodynamics, and here we've already, I've told you the story of nitroglycerin and Viagra, sildenafil. Another example would be warfarin and aspirin in terms of clotting. What's the mechanism of action of warfarin? Does anyone know?
Vitamin.
It inhibits the synthesis of vitamin K dependent clotting factors, right? So you inhibit the synthesis of particular clotting factors, which then will slow blood clotting. How does aspirin inhibit clotting? It's antiplatelet, right? And it does that by inhibiting covalently cyclooxygenase. And is the target there decrease in prostaglandins?
Thromboxane.
It's thromboxane A2, right? And so here, from a pharmacodynamic standpoint, you have two drugs that retard clotting by different mechanisms, and so you have synergism. 1 + 1 = 5. From a pharmacodynamic standpoint, rather than inhibition, you can also have positive interactions, and here we have common combination drug therapy to treat hypertension. We already spoke about hydrochlorothiazide, which is a diuretic, right? So it decreases blood volume, which then will decrease cardiac output, blood pressure goes down. What is metoprolol?
Beta blocker.
It's a selective beta-1 antagonist, and that will decrease the force of contraction of the heart and heart rate. Hydrochlorothiazide decreases blood return to the heart. You may be familiar with something called the Frank-Starling law, right? So you have a decrease in blood entering the heart, which then decreases cardiac output. Metoprolol decreases heart rate and force of contraction. So bringing them together, you'll see a substantial decrease in blood pressure, and they act synergistically, in this case, in a sort of very therapeutic, positive way. Any questions about anything I've been talking about so far? No? All right, we'll get started on the next handout. I think I'm going to exit share here. Stop share. Stop that for a moment. And then what we're going to do is, no, we're going to share again. And we're going to go to this. Let me share that. And then what we're going to do is close this. And we are going to go to modules. And we'll do pharmacodynamics 2. Sometimes I find the connections here in this hall slow. By the way, is anyone living on campus? You're all living off campus?
Yes.
What part of town?
Me?
Yeah.
Mount Lebanon.
Mount Lebanon?
Yeah.
How long is the commute?
20 minutes.
How about you? Where are you staying?
Downtown,
Downtown. Do you walk here?
I take T.
Oh, for free, right? Yeah. Where you live?
Wilkinsburg.
Williamsburg.
Wilkinsburg.
Wilkinsburg.
Just after
Okay.
the Creek Park.
All right. Where you live?
Squirrel Hill.
Squirrel Hill. Okay.
Squirrel Hill.
Ah,
Bloomfield.
Bloomfield. So all around the town, right? Anyone actually drive here other than you?
I don't drive.
Oh, you don't? No?
No.
Okay. Anyone drive here? Traffic, right? Okay. Why is this taking so long?
Maybe refreshing it would be a good idea.
Let me see if I can. Back this up. We'll go back and see what happens. We'll try that.
See.
There we go. Okay. Okay. Receptor sites and mechanisms of action. You can have drugs that work by alter ligand synthesis. So this is where the mechanism is related to changing the synthesis of an enzyme, right? So another common class of drugs used to treat hypertension are angiotensin converting enzyme inhibitors that block the conversion of
Angiotensinogen to angiotensin.
angiotensin 1 to angiotensin 2,
Okay.
right? So angiotensin 2 is one of the most potent vasoconstrictors, and it also promotes the release of aldosterone, which promotes sodium and water retention. NSAIDs, we already spoke about cyclooxygenase. L-DOPA, that affect endogenous ligand kinetics, gets metabolized to dopamine. Alter ligand storage. In terms of mechanism of action, can anyone tell me how amphetamine works?
It alters the storage of norepinephrine
And dopamine.
and dopamine.
How? Anybody? It's a releaser.
Yeah.
So you have norepinephrine and dopamine in presynaptic storage vesicles, and amphetamine is what is called an indirect acting agonist, where it facilitates the the release of dopamine or norepinephrine without an action potential. It just causes it to leak out, altering ligand storage, alter ligand metabolism. Selegiline is a selective monoamine oxidase inhibitor that inhibits the breakdown of dopamine. Alter ligand transport. Both of these drugs have similar mechanisms of action in that they block the reuptake. Cocaine blocks the reuptake of catecholamines, and selective serotonin reuptake inhibitors, as the acronym suggests, blocks the reuptake of serotonin. SSRIs are frequently used to treat both anxiety and depression. Is cocaine legally dispensed in this country? What do you think? How many say yes? Sort of?
Yeah.
How many say no? It is a drug of abuse, but you can get people cannot get a prescription for it, but it is used for a couple of things. It is used for analgesia for eye surgery, and also for rhinoplasty, nasal surgery. And the reason is it's a power, because it inhibits the reuptake of norepinephrine. It is a powerful vasoconstrictor. The nose is highly vascular. So if someone is having nose surgery, they can apply cocaine topically, and it will allow for a relatively blood-free surgical field. And it's also a very potent local anesthetic, so you can sort of cut away and they feel nothing. So cocaine is what is called a Schedule II drug, highly addictive, but it is legal in this country. Schedule I drugs include, in this country, heroin, LSD, things of that sort that are deemed not to have any therapeutic benefit. I think up until the last few years, marijuana was considered, or tetrahydrocannabinol was considered Schedule I, but now it's less than that. I think in some states it could be prescribed for various infirmities. Good. Can anyone give me an example of a therapeutic use of delta-9 THC or marijuana? What do you think? Any therapeutic benefit?
For anxiety.
Sorry,
Go ahead.
Like chemotherapy-induced vomiting.
Right. And?
I suggested as an anti-anxiety medication.
True. Especially anti-anxiety linked to post-traumatic stress disorder. Okay. But in terms of chemotherapy, chemotherapy also can involve not just nausea, vomiting, but it also, chemotherapy can also, maybe because of the nausea and vomiting, cause loss of appetite. And one of the well-known effects of marijuana is it increases appetite. So sometimes it's prescribed to patients who are almost sort of cachexic. I mean, they have their food intake is really low, and you can prescribe it for that. I'm sort of I have to confess a weakness on my part. I like certain television shows. Have any of you ever seen a television show called The Big Bang Theory? Did you ever see the episode where the boys are out camping and they inadvertently eat some, I think they were brownies laced with marijuana, and they get very hungry? I thought it was really funny. All right. Receptors associated with extracellular processes, tissue plasminogen activator that stimulates or activates plasminogen, which is involved in what? What does plasminogen do?
Thrombosis.
Platelet aggregation.
Say again?
Platelet aggregation and blood clotting.
Plasminogen dissolves blood clots, right? And so tissue plasminogen activator sometimes is used therapeutically to treat patients who have experienced an ischemic stroke or myocardial infarction. Got to be careful though with the dosing. I think I've read that there's a famous case in which the Prime Minister of Israel, Ariel Sharon, was administered tissue plasminogen activator to get rid of a clot that had caused an ischemic stroke, and it converted him. He wound up having a hemorrhagic stroke instead. And actually, mortality associated with hemorrhagic strokes is substantially higher than mortality from ischemic strokes, and he died.
So Dr. Johnson, one of my friend, he was placed with drug-eluting stent, where they had this
Coronary artery stent?
Yes.
Uh-huh.
And they had this tissue plasminogen activated, like
Right.
enveloped on the stent, so it kind of sheds from the stent.
Which is very clever and very good. One of the problems with placing stents in arteries, especially coronary arteries, to the extent that the stents are made of a foreign material, that generally will stimulate clotting. And so if you have a stent that's impregnated with something like a tissue plasminogen activator, that will tend to maintain the patency of the stent so it doesn't get clogged by a new clot. So that's how long ago did he have the stent placed?
It was 2014, and since then I'm not in touch with him.
Oh, okay. So hopefully he's still living and hasn't had another heart attack. Okay, very good. We've already spoken about receptors used by anti-infective agents, and penicillin binds to the enzyme DD transpeptidase, resulting in inhibition of bacterial wall synthesis. We've already gone through that. That regulate ionic environment. Digoxin, we've already spoken about, blocking sodium potassium ATPase pump. Proton pump inhibitors that are used to treat gastric ulcers by inhibiting hydrogen potassium ATPase pump, which is in large measure plays a significant role in the production of gastric acid. Receptors that regulate signal transduction pathways, two major functions of receptors. Functions of receptors have on the one side binding of a ligand, which then can activate the receptor, and then once the receptor is activated, the receptor can then trigger a signaling cascade, which then can result in a response. So, structural and functional families in the body of receptors. The most abundant, at least in terms of types of receptors, are G-protein coupled receptors. They have wide-ranging ligands. Just some examples include histamine, norepinephrine, angiotensin II receptors, and they're called G-protein coupled because the transducer is a G protein that then will activate other enzymes, and certain drugs that bind to these G-protein coupled receptors include ranitidine. What kind of drug is that, and which receptor does it bind?
H2.
H2 receptors, which then will decrease the release of gastric acid, right? Phenylephrine binds to which receptor? Alpha 1, right? And it's a potent vasoconstrictor. Losartan blocks angiotensin II receptors, so it's a vasodilator. So that's one family of receptors. Another family is ion channel receptors, acetylcholine, glutamate. And you can see that the channel for glutamate is calcium, sodium, ketamine. Okay. Tell you a true story back from when I was a graduate student. And this, at this point, you all have selected your graduate advisor. Just want to comment that the relationship between a graduate student and their advisor tends to be close. It's very much sort of like a master-apprentice relationship, where your advisor is essentially training you to become scientists. But in my experience, I've had great advisors, and I've had graduate advisors who were a disaster. True story. I finished my master's degree in pharmacology at the Massachusetts College of Pharmacy in Boston. And because I lived in Maine, my advisor made an arrangement with another pharmacologist at a university in Maine where I lived. And I was in the lab 7 days a week, okay, doing things like weighing rats, feeding rats, measuring food intake, all of those kinds of basic things. And occasionally, he would ask me to pick up some pentobarbital from a hospital, or actually from my advisor in Boston. Pentobarbital had already been preloaded into syringes, and he told me, well, we're going to be sacking the rats, sacrificing the rats with an overdose of pentobarb. To make a long story short, he was actually abusing the pentobarb himself. And at one point he came to me that, the associate dean of, this was in a medical school, had become suspicious of this use of pentobarb. And he said that if the associate dean asks you what this is being used for, I should just say it's being used to sacrifice animals. And so I went to another pharmacologist in the department, and I shared with him that interaction. He said, oh, you've got to go right to the dean and tell him what's going on, which I did. And so I'd been working on this project for well over a year, in the lab every day. And so when it was found out, it turned out that this pharmacologist, who was a brilliant pharmacologist, I mean, he was very talented, very bright, was not just abusing pentobarb, he was also abusing ketamine. And he was abusing just about anything he could get his hands on. And so after the dean found out, he went into rehab for an extended period of time. I went back to Boston, and I lost a year's worth of work, and I had to start from scratch on a brand new project. And it added a year it took me to finish my degree. The point is, I know all the faculty here at Duquesne very well. They are all very good people. You do not need to worry. Okay. Do not worry. But that was my experience. Just the end of the story. And we'll probably, we'll finish this table and then, but I'll finish the story first. I had left the lab back in Boston. He came back after rehab and was, functioning again, teaching pharmacology to the medical students. Unfortunately, though, he became romantically involved with 3 medical students concurrently at the same time. And so, yikes is right. And so, eventually the 3 students got wise, that they were not the only one in his life, and they confronted him. And he threatened to sue them for defamation of character. So one student, he married one of the students. The other student just sort of walked away, just didn't want to have anything to do with him. And the third student wound up turning him in. The professor sued this student for defamation of character. It went to court. It went to trial. And the outcome of the trial was, he was suing her for compensation. The court ordered him to pay her. He appealed to the state Supreme Court, and they wouldn't even hear the case. And at that point, the university fired him. And so he went back to North Carolina, where he was originally from, wound up working in a convenience store and died young, probably from drug abuse. So very sad story. And so, on the one hand, I feel bad for him, but on the other hand, I'm still angry that I lost a year of graduate school. The point is, the relationship that a graduate student has with their mentor is close, but there has to be a great deal of trust involved. And, the graduate advisor can have a tremendous impact on the student in terms of facilitating their progress, or if they're not doing their job well, hindering their progress. In the same way, advisors really rely on the work of the graduate student to generate data to publish papers. And so if the graduate student, to tell you another story, where I was the faculty member and I had a graduate student, and we were working on a clinical project where we were administering drugs and then testing memory function. And so the student was running the project, and I was getting back sheets that had data on them where the subjects had to fill out the sheet. And I started looking at these sheets, and the writing all looked identical from subject to subject to subject. And so the graduate student was fabricating the data, which is disaster, because there's money involved, there's lost time involved. The graduate student obviously had to leave the program because of that plagiarism is really serious. But that set me back. I had all this fraudulent data and money and time that I invested in the project that was no good. My point being that the relationship between an advisor and an advisee is a close one that depends both on trust and honesty and good intent. So as I say, all the faculty members in Duquesne are whom I've known for over 10 years. They are all excellent, excellent people who will do their best for you. So you could feel good about that, But then on the other hand, you're obliged to be honest with them and work hard, get your project done, and you can get out of here. I'm just sort of curious, who are your advisors?
So I work with Dr. Lauren O'Donnell.
Oh, yes, she's great. So, as you know, she just had one of her students defend.
Yes.
She's off. Yashika. She's on her way to UCLA for a postdoc. Who are you working with?
O'Donnell as well.
Oh, okay. So I love that woman. She is great. Who are you working with?
Dr. Leek.
Oh, another outstanding, very dedicated, very prolific. She publishes a lot. Very bright. I think the student that we have online is also a lead student.
Yes.
Who are you working with?
With Nandapi.
Oh, yeah. Paula and I, Dr. Whit Enderby and I go back a long way. She is very productive, very compassionate, feels, gets a very close relationship. But you'll work very hard. You'll all work very hard, especially you. And who are you working with?
I'm also in Dr. Whit Enderby's lab.
Oh, okay. Great. So she does a lot of work related to bone, right? Is she still doing bone projects?
She's branching into
Estrogen
muscles and
muscles.
fat. Yeah.
Right. Melatonin.
Melatonin,
Yes.
yes.
Right. And who are you working with?
Dr. Bay, Dr. Misuk Bay.
Oh, okay.
She's a new faculty.
She is brand new.
Yes.
And so, let's see, I'm trying to think. She's working on some interesting stuff. I don't know her nearly as well because she's relatively new.
Yeah.
Good luck.
Thank you.
Okay. But I'm confident. I've met her and I've worked with her a little bit, and she's very good as well. So I think you're all in good stead with having excellent advisors. So that's great. Let's just finish up this page and we'll be done. Transmembrane enzymes, growth factors, HER2. What disease is HER2 receptor? What is that? HER2, that's an acronym for what?
Breast cancer.
Human epidermal receptor 2, and it plays a role in binding, I believe it's growth factor, which plays a role especially in breast cancer. And the blocker for that is Herceptin, transmembrane non-enzyme interleukins, okay, soluble tyrosine kinases. Those are all second messengers. Nuclear receptors, estrogen, cortisol, and coactivators. Tamoxifen is an antagonist of the estrogen receptor, or it's a modulator of the estrogen receptor. Prednisone is an agonist for the glucocorticoid receptor. Intracellular enzymes, nitric oxide. What effect does nitric oxide have on blood vessels?
It dilates.
It's a dilator, right. Cyclic GNP is the membrane or the transducer. Nitroglycerin is an agonist. Okay, so actually, nitroglycerin enhances or increases cyclic GNP, right? And then we were talking about Viagra. It inhibits the breakdown of cyclic GNP by inhibiting a phosphodiesterase. So those are just examples of different kinds of receptors, and where we'll go from here on Thursday. We'll take a little more detailed look, starting off with G protein coupled receptors. Anything else before we stop? Okay, good class. I'm sorry I've given you so many stories, but I think that at least my philosophy of teaching is an hour and a half is a long time, and unless you find ways to hold attention, you'd all be sort of sleepy by now. So, see you all on Thursday.
Thank you.